Our next topic is going to be gallbladder disease. And basically, let's start out by talking about a patient who has a constant right upper quadrant pain. This patient's going to have fever, they have leukocytosis, and they have this right upper quadrant pain that doesn't go away, okay? We're going to suspect acute cholecystitis. And how are we going to diagnose acute cholecystitis? Our diagnostic test is going to be a right upper quadrant ultrasound. On the right upper quadrant sonogram, we're going to see gallstones, a thickened gallbladder, and pericholecystic fluid, which is going to confirm our acute cholecystitis. If our ultrasound is negative, but they still have these biliary type of symptoms, we're going to do a HIDA scan. Now, when we've diagnosed acute cholecystitis, if on the ultrasound we see gangrene or perforation, how can this present? This can present with generalized peritonitis or emphysematous cholecystitis. If we see any of these, it's going to show us gangrene or perforation, and at this point we're going to have to do an emergent laparoscopic cholecystectomy. So if it's gangrenous or it's perforation shown by emphysematous cholecystitis, we're going to do an emergency laparoscopic cholecystectomy. Now, we're going to manage them based on whether it's a calculus or acalculous stone. If it's calculus, if it's calculus and they're common bile duct stones, we're going to do an ERCP. ERCP is going to be our most accurate diagnostic test, and we're going to admit and do supportive care with IV fluids, NPO, analgesia, and IV antibiotics. And if they're gallbladder or cystic stones, we're going to just go straight to admitting them with supportive care for 24 to 48 hours, IV fluids, NPO, analgesia, and IV antibiotics. Antibiotics, why? Because it's itis. It's an infection, so they're going to be given antibiotics. If it's a high-risk patient with non-cholesterol stones, we're going to be doing an electrohydraulic lithotripsy. If it's a high-risk patient, we're going to do a T-tube percutaneous cholecystotomy. So basically, if they're not high risk, we've admitted them. We've done supportive care for 24 to 48 hours. And then we're going to wait about 6 to 12 weeks. And we're going to do a laparoscopic cholecystectomy. Okay? So they got calculus stones or acalculus. After we admit them, we're going to put them NPO, we're going to do NG suction, we're going to do IV fluids, and we're going to give them antibiotics and analgesia. And we're going to wait about 6 to 12 weeks, and we're going to do a laparoscopic cholecystectomy. Remember, if there's acute cholecystitis and we see gangrene or perforation characterized by emphysematous cholecystitis or generalized peritonitis, anytime you see peritonitis, what do you have to do? You have to do an emergent laparoscopic cholecystectomy. But if not, we're just going to admit them, do supportive care, stabilize them, and wait about 6 to 12 weeks before we do laparoscopic cholecystectomy. If it's high risk and they have cholesterol stones, we're going to do electrohydraulic lithotripsy. But if they're high risk and they don't have cholesterol stones, we're going to do a percutaneous cholecystotomy. Now, complications of laparoscopic cholecystectomy can be post-surgical strictures. And also, it can have bile salt-induced diarrhea post-cholecystectomy. If it's bile salt-induced diarrhea post-cholecystectomy, you're going to treat them with cholestyramine. But a post-surgical stricture can actually cause acute cholangitis. Now, acute cholangitis, this is the way you're going to differentiate between cholangitis and cholecystitis. Cholangitis is going to have the presence of jaundice. Okay. On top of that, there's a triad for cholangitis, which is the fever, the right upper quadrant pain, and the jaundice. Cholecystitis has no jaundice. Cholangitis, itis as well, is going to have jaundice. These guys have a high fever and white cell count also because they're going to be septic because of the itis. They're both itis, so they're both going to be infections. But what characteristic finding you're going to be looking for on acute cholangitis is they're going to have a very high level of alk phos. So basically, what you're going to do in these patients is blood culture and plus antibiotics. The antibiotics that you can use are beta-lactam and lactamase combinations, such as piperacillin tazobactam or ampicillin gent or imipenem levofloxacin. Plus, you're going to give them IV fluids. Then, remember that emergency decompression of the common bile duct is going to save these patients' life. Okay, cholangitis is much worse than cholecystitis, so you're going to have to do an emergency ERCP. This emergency ERCP is going to both diagnose them and treat them. If they have no improvement on the ERCP, you can actually do a biliary decompression and drainage. If the post-surgical stricture can't be successfully corrected, you're going to do a laparotomy. And if there's no improvement, you can do urgent biliary decompression by transhepatic aspiration. So if there's no improvement with the ERCP, you're going to do transhepatic aspiration. And then eventually, in acute ascending cholangitis, a cholecystectomy is going to follow. In patients that are penicillin allergic, you're going to do aztreonam and metronidazole, or you can give a third-generation cephalosporin plus metronidazole. So, real quick, let's do it again. Gallbladder disease, right upper quadrant constant pain. You're going to do a right upper quadrant ultrasound. You're going to diagnose acute cholecystitis because there's going to be gallstones and a thickened gallbladder with pericholecystic fluid. If there's gangrene or perforation, you're going to do emergency cholecystectomy. Otherwise, you're going to just stabilize them, and you're going to wait 6 to 12 weeks before you do a laparoscopic cholecystectomy. If the ultrasound is negative, you're going to do a HIDA scan. And after you do a cholecystectomy, a complication can be a post-surgical stricture or bile salt-induced diarrhea. If it's bile salt-induced diarrhea, you're going to give cholestyramine. The stricture can cause an acute cholangitis, and the acute cholangitis is going to be characterized by Charcot's triad, which is right upper quadrant pain, fever, and jaundice. What you're going to have to do is blood culture plus antibiotics. The combinations can be amp and gent, imipenem, or levofloxacin, and you're going to give them IV fluid. This is going to be much worse than cholecystitis. So you're going to have to do emergency decompression of the common bile duct, and this is going to save their life, okay? And you're going to do this via ERCP. If it can't be successfully corrected, you're going to be going to a laparotomy. And if there's no improvement after the urgent biliary decompression, you're going to do a transhepatic aspiration. And this pretty much covers everything you need to know on cholecystitis and cholangitis. A couple of other things that I want to throw in that are just easy points is with Charcot's triad, you can actually get a patient with hypotension. And if the patient has Charcot's triad and hypotension plus sepsis, if hypotension plus sepsis occurs with the Charcot's triads, this is known as Raynaud's pentad. And Raynaud's pentad actually has a much higher mortality rate. The mortality rate reaches 50%. And this pretty much covers everything that you need to know. And I hope you guys made sense of this and study hard, okay?